You can start now, I think. Benulin?
Okay, sir. Good evening, everyone. Welcome to ISA Online PG class, which is held every Monday at 6:30 p.m. Myself, Dr. Srihari Priya, Assistant Professor at IMS and Some Hospital, will be your sprint coordinator along with Dr. Viduri. In this session, we will delve into a case discussion on ARDS, its pathophysiology and management. First described in 1967 by Oshbach and colleagues, ARDS has remained one of the most challenging syndrome in critical care medicine, ever evolving in definition but consistent in its high mortality. But before we begin with the academic session, let us begin blessings of Ma Saraswati with this Saraswati Vandana. May I now request Dr. Supinder Bajwa sir, Honorary Secretary ISA National, to please address the audience.
Thank you, Dr. Haripriya. Actually, today's class we have specially kept because this is one of the part of our lower airway management in our forthcoming National YuvaCon at Hyderabad on 26th and 27th July. So just a continuation of that part. The topic chosen here by Dr. Dalim Bede and team is one of the very apt topic, the ARDS. I think it's a multi-dimensional topic if you cover from different clinical aspects. Almost every third or fourth case in our ICU is of ARDS when we treat them. And a simple case of pneumonitis is going to the ARDS, simple cases of sepsis going to the ARDS. And numerous strategies, including that low tidal volume strategies, the optimal PEEP, considering the auto PEEP, and the prone ventilation, and depending upon the body, BMI. So many strategies are there. I think the individualized approach is very, very important. And we are always faced with this a challenge when we are treating such patients who develop a full-blown ARDS. Rather, I think from the beginning only, but the newer concept emerged, even in the beginning, if you suspect with the newer modalities like ultrasound coming into the focus coming into play, you are having the diagnostic picture of ARDS. You may be able to have a better prognosis if you do early interventions depending on the patient's characteristic and traits and the clinical profile. So I think we are going to have a very good class from Dr. Dalim Kumar Baidia from my own homeland, another second homeland rather, Guwahati, AIMS Guwahati. So I welcome the team from AIMS Guwahati, and I switch back to Dr. Haripriya for for further proceeding to the class.
Thank you, sir, for your valuable insight. Now I request Dr. Vinulin, my co-screen coordinator, to introduce today's esteemed faculty and outline the session's format and rules. Over to you, Dr. Vinulin.
Thank you, Dr. Sri Haripriya. Myself, Dr. Vinolin Maria Sebastina, consultant anesthesiologist in Government General Hospital, Manaparai. I'll be one of the screen coordinators for today. Now, on behalf of ISA National, I proudly introduce a faculty for today. Our first faculty will be Professor Dr. Talim Kumar Baidya. Sir is a professor and head of Department of Anesthesiology, Critical Care and Pain Medicine at AIMS Guwahati. Sir has more than 16 years of PG teaching experience, and his special interest lies in the field of critical care medicine, difficult perioperative outcome. Sir has been associate editor of Indian Journal of Anesthesiology and has been past assistant editor of JOACP, and he's an examiner of DM Critical Care Medicine and MD Anesthesiology, and he's an editor of Washington Manual of Critical Care. Sir has been awarded Best Researcher ISA Delhi 2022 and Best Oral Paper at World Intensive and Critical Care Conference, Istanbul. And Sir has a mammoth number of publication, which is 210, which includes 83 original articles and 24 meta-analysis. Sir's publication numbers are jaw-dropping, which is he has a H index of 31, I-10 index of 72, and 4,600 citations. I welcome you, sir, for today's class. Our next faculty for today is Dr. Anirban Bhattacharjee. He is an assistant professor of Department of Anesthesiology, Critical Care and Pain Medicine at AIMS Guwahati. He has more than 2 years of teaching experience, and his special interest lies in the field of critical care medicine. His achievements are Sir has been organizing secretary of TRACE ICU meetings organized by AIMS Guwahati. Sir has been co-organizing secretary of East Zonal Critical Care Conference 2023 and has been executive committee member of ISCCM Guwahati City Branch. He has authored 11 scientific articles in national and international journals and has authored book chapters, including contribution to the Washington Manual of Critical Care. I welcome you, sir, for today's class. And now, a small announcement for the audience. Audience are requested to keep themselves muted and keep their videos off throughout the session. If you have any queries, kindly put it in the chat box, which will be duly addressed by the faculty. Kindly abide by the rules. Now, I request our beloved faculty to introduce the postgraduate and take the session forward. Over to you, sir.
Thank you, Dr. Vinolin, for your kind introduction. And first of all, thank you, Dr. Bajwa, for providing us with the opportunity to present in this prestigious national class. So today we'll be discussing on a very important topic, ARDS. And as an anesthesiologist and intensivist, you know, ARDS is an integral part of our critical care practice, and we should know all the important details about the managing a case of ARDS. However, there are certain concepts which are a bit difficult and continuously evolving. So the case will be presented by our postgraduate student, Dr. Srishti Kumari, and myself and Dr. Anirban will be moderating the entire proceedings. So Dr. Srishti, you can start with your presentation.
Good evening, everyone. Today's case-based discussion is on the topic severe acute respiratory distress syndrome. Patient particular, a 19-year-old male hailing from Chansari, Assam, is a student by occupation. He presented with the chief complaint of fever for 2 days, dry cough for 2 days, and shortness of breath for 1 day. History of present rare, low-grade intermittent fever for 2 days, which was gradually onset, not associated with chills or rigors. No diurnal variation, and the fever resolved on medications. Patient complains of acute onset of 3 to 4 drops of dry cough for the 2 days, which worsened at night and aggravated on lying down, necessitating upright or sleeping in a sitting position. He complained of shortness of breath, which was acute in onset and rapidly progressive for 1 day. He has no significant medical or surgical history. He consumes a rice-based non-vegetarian diet and is a non-alcoholic, non-smoker, non-tobacco chewer, and not addicted to other substances. He has no significant medication history, no significant family history, has no significant allergy history. He belongs to an upper middle class family and has been immunized till date. Coming to general examination, the patient was of average build, conscious, well-oriented, no pallor, icterus, cyanosis, clubbing, edema, dehydration, lymph node enlargement or engorged neck veins present. No abnormal faces. The vitals, blood pressure was 130 by 90 millimeters of mercury measured at right arm in supine position. However, the pulse rate was 120 beats per minute, which was regular. Respiratory rate was 40 breaths per minute with accessory muscles of respiration in use. And the room air saturation was 84%. Temperature was 37 degrees Celsius. Coming to the systemic examination, respiratory system. On inspection, the shape of the chest was normal. Trachea appeared to be incentral. There was no dilated veins or visible pulsation. Bilateral chest movement and expansion was equal. On palpation, trachea was incentral. Vocal fremitus normal. No local temperature rise or tenderness present. On percussion, it was resonant on all lung areas, and on auscultation, vesicular breath sounds were heard. Bilateral, fine inspiratory crepitations were heard over infraaxillary and infrascapular regions. Cardiovascular examination. On inspection, no local bulge, visible pulsation, engorged veins, or deformity observed. On palpation, apex beat was felt in the fifth intercostal space, 1 centimeter medial to the mid-clavicular line. No thrill or parasternal heave felt. On auscultation, S1 and S2 were heard, no added murmurs present. Abdominal examination. On inspection, abdomen is neither distended nor scaphoid. No visible peristalsis, pulsation, scar, engorged veins, bruises, or pigmentation observed. On palpation, no localized abdominal mass felt or fluid thrill felt. No rigidity, tenderness, rebound tenderness, or guarding present. On percussion, tympanic note was observed and shifting dullness was absent. On auscultation, vowel sounds were heard. Central nervous system, higher mental functions were normal. Bulk, tone, power were normal in all limbs, no cerebellar signs. With normal gait, no neck rigidity. Cranial nerves were intact and reflexes were intact. Coming to summary, a 19-year-old male presented with severe respiratory distress and had history of fever for 2 days, dry cough for 2 days, and shortness of breath for 1 day. On examination, he was tachycardic, tachypneic, with use of accessory muscles of respiration and fine inspiratory crepitations heard over lung fields. So the provisional diagnosis here will be a 19-year-old male with acute hypoxic respiratory failure due to community-acquired pneumonia, probably viral in etiology.
Okay, Srishti, so a young male with fever, cough, and shortness of breath, okay?
Yes,
And
sir.
on your examination, there was hypoxia, tachypnea, tachycardia, and respiratory distress. So, why do you think it is a community-acquired pneumonia and specifically probably viral in etiology?
Sir, the patient had no previous hospital admission, and history is not suggestive of any immunocompromised state. Most probably, it must be a community-acquired pneumonia. And since the patient presented with dry cough with bilateral crepitations heard, most probably it points in the favor of viral etiology.
Right. So, although it's difficult to say at this moment, in bacterial pneumonia, the cough is usually a wet cough, and you tend to get more of an unilateral finding, although bilateral finding can be there. Right. Viral pneumonias are usually associated with a viral prodrome also, but in many of the cases, overt viral prodrome history is missed as well. So, is the data so far is adequate to diagnose ARDS? What do you think?
No, sir. Till now, we haven't ruled out any underlying cause, any underlying cardiac cause. Moreover, we need to see the degree of hypoxemia with the help of PF ratio, and which can be done with the blood gas analysis to classify the degree of hypoxemia and classify ARDS. And also, we need imaging modalities such as chest X-ray, which should be showing bilateral pulmonary infiltrates, which could not be explained by other pathologies.
Right, exactly. So
Yes.
this leads us towards the discussion of the definition of ARDS. So I think we can start with an MCQ if you move ahead.
Yes, sir.
So this is an MCQ for the audiences. You can write the answers in the chat box now. Shrishti, can you just read it out, the MCQ?
Yes, sir. Which of the following is false statement regarding the diagnosis of ARDS? The Berlin definition requires ruling out cardiogenic pulmonary edema by measuring pulmonary capillary wedge pressure. Option A. Option B. AECC definition defines acute onset as the onset within 7 days of initial insult. Option C. Patients on HFNO cannot be defined as having ARDS due to absence of CPAP or PEEP application. Option D. All are false.
Okay, we can just pause for 30 seconds or so and see how many responses are coming, and then we'll move ahead with the elaboration on the definitions. Okay, so I can see most of the answers are C here. I think everyone has answered C. So to discuss further on the definitions of ARDS, I would like to invite Dr. Anirban, because we have three different definitions. Initially the AECC, then Berlin, and recently global definition. It has evolved over a period of time. The definition of ARDS has evolved, specifically with better understanding and availability of better treatment modalities. So, Anirban, can you just discuss a bit on the evolution of the definition of ARDS? Srishti, you can move ahead into the slides.
Thank you, sir. So, as Srishti was mentioning, so she was probably referring to the Berlin definition, which is the most popular definition of ARDS that we have been using for the last 10 to 12 years. So it was proposed in 2012. So how do we diagnose ARDS based on the Berlin definition? So there are some criteria. The timing of onset, where the new or worsening respiratory failure should start within 7 days of a onset of a clinical risk factor. So these risk factors can be pulmonary or extrapulmonary risk factors. So common pulmonary risk factors are pneumonia, aspiration, inhalational gas injury, and in case of extrapulmonary, the common causes are sepsis, trauma, pancreatitis, so on and so forth. So once you have this initial clinical risk factor, if you have developed new or worsening respiratory failure within 7 days, then it matches the criteria of Berlin definition. You also need to have an imaging to support your diagnosis. So specifically, it has to be a bilateral infiltrate consistent with pulmonary edema not fully explained by effusions, atelectasis, nodules, or masses. So you can do that on the basis of a chest X-ray or a CT scan as per the Berlin definitions. Now, the severity of hypoxemia is measured by measuring the PaO2 FiO2 ratio. So as Srishti rightly mentioned, we need a ABG for doing that as per the Berlin definitions. One important caveat is that you have to measure the severity only after application of a 5 centimeter water of CPAP or PEEP to your patients. Now, one thing that Dr. Srishti was mentioning, that we need to rule out the cardiogenic cause. But the Berlin definition has specifically mentioned categorically that if your patients have known clinical risk factor for ARDS and you have a very strong clinical suspicion of ARDS, you need not always do an echocardiography to rule out cardiogenic cause before diagnosing ARDS. In cases where there is a strong clinical suspicion of cardiogenic pulmonary edema or patient does not have traditional risk factors, that is when we do formal echocardiography to rule out cardiogenic pulmonary edema. Can we move to the next? Yes. So as Dalim sir was mentioning, the definition of ARDS has evolved over the last 2 decades. The first formal definition came to be in the year 1992 by the American European Consensus Conference. So how they defined ARDS? They mentioned acute onset, but they did not give us a time frame back then. And they have classified the severity of hypoxemia into acute lung injury and ARDS. So anyone having a PaO2 FiO2 below 300 was diagnosed to be having acute lung injury. More severe cases of acute lung injury with a PaO2 FiO2 ratio below 200 were defined as ARDS. Now, the severity of hypoxemia did not require any application of a PEEP before measuring the PaO2 FiO2 ratio. And the most important loophole in the diagnosis of ACC was that they mandated the use of pulmonary capillary wedge pressure to rule out cardiogenic cause of ARDS. So which is not feasible in majority of the cases, and that is the reason why the Berlin definition did not go ahead with the criteria anymore. Next. However, as over the last decade, we have seen changes in the way we diagnose and manage ARDS. Specifically, we have been using more and more point-of-care ultrasound, as Bajwa sir was also saying. So that has come up in a big way in our ICUs, and also we have the non-invasive respiratory support for ARDS has grown in a big way, specifically the use of high-flow nasal oxygenations. So that is why to evolve along with in that line, so new global definition was released in the year 2024, where the risk factors and origin, timing of onset remains same. The specific changes are in the imaging. Now, in ultrasound, if you get characteristic ultrasound pictures like B lines, shreds, which are bilaterally present, so that can be used as an imaging criteria for diagnosing ARDS. Specific categories of ARDS have been mentioned. The non-intubated ARDS gives the provision for diagnosing ARDS even if the patient is not intubated or patient is only on high flow nasal oxygen, we can diagnose ARDS. So I am not going to go into the numbers. And the provision for diagnosing ARDS in resource limited setting has also been given by the Kigali modification, where instead of PO2 FiO2 ratio, which mandates an arterial blood gas, you can diagnose ARDS on the basis of SpO2 FiO2 ratio. So this increases the feasibility of diagnosing ARDS in a formal manner in resource limited settings as well. Next. So we move back.
Right. So, putting it all together, now we can diagnose ARDS based on imaging of either chest X-ray or CT scan or point-of-care ultrasound. And for oxygenation, we can use either PO2 FiO2 ratio or SpO2 FiO2 ratio, even in the absence of a arterial blood gas being available. And the pressure support, that is, sorry, the PEEP or CPAP that was initially talked about, we can do that in the absence of a NIV or intubated patient just by using an HFNO with 30 liters per minute of flow, Right. So this has actually expanded the definition largely. Now, if we just quickly try to answer our MCQ, I think all the options are false, not just C, right? Uh, can you quickly go back, Srishti, to the MCQ? Yes. So all the options are actually false. So the answer will be D here, right? So let us move ahead with the further discussion on the case.
In the ER, when the patient was presented, he was connected to non-rebreathing mask at 15 liters per minute. The saturation improved from 84 to 86%. However, the respiratory rate continued to be 36 breaths per minute with accessory muscles of respiration still in use. Patient was conscious and oriented. Blood gas analysis revealed partial pressure of oxygen to be 70 millimeters of mercury and that of carbon dioxide was 28 millimeters of mercury. Then the patient was shifted to ICU. Here the patient was connected to HFNC at 60 liters per minute and FiO2 of 1. The saturation improved to 90% and the respiratory rate to 35 breaths per minute. The patient was conscious and oriented. And blood gas analysis was done, which revealed the partial pressure of oxygen to be 66 millimeters of mercury, and that of carbon dioxide was 32 millimeters of mercury. Point of care ultrasonography was done. Here we can see anteriorly well-spaced B lines were present, and in the PLAPS point, in the second picture, we can see that there is subpleural consolidation with spreading or irregular borders. 2D transthoracic echocardiography was done, showing a four-chamber apical view where we can see left ventricular contractility appears to be normal and the right ventricular is within the normal limits.
Right. Okay, Srishti. So at this point, we have put the patient from NRBM to high flow nasal oxygen inside our ICU, right?
Yes,
So
sir.
we know that HFNO provides better oxygenation specifically in hypoxemic respiratory failure. So can you just explain what are the possible mechanisms by which HFNO improve oxygenation?
Yes, sir. Sir, HFNO provides warm, humidified, high flow and FiO2 of 1%, FiO2 of 100%, and it also increases the end expiratory lung volume, which enhances the alveolar recruitment. Since it provides a high fraction of inspired oxygenation, it improves the partial pressure of oxygen, and this decreases the respiratory drive, decreases the respiratory rate and work of breathing of the patient. Moreover, there is increased dead space washout in HFNC.
Good. So I think we can move ahead. I think we have an MCQ here. Yeah.
So I will read out the MCQ.
Yeah.
Which of the following statement is false? Option A, HFNO improves oxygenation by providing CPAP. HFNO reduces dead space ventilation. Option C, HFNO increases respiratory drive. Option D, ROX index below 2.85 is associated with high risk of HFNO failure.
Right. So the students can put down the answers quickly in the chat box. We pause for a few seconds. Yes, this time most of the answers are right. So I guess the answer should be C. As Srishti has already explained how HFNO improves oxygenation, and of course it reduces the respiratory drive and reduces the work of breathing. So we can move ahead, and Srishti, you can show the various mechanisms. We have a beautiful diagram to emphasize on how the high flow nasal oxygen reduces the work of breathing, improves humidity, provides targeted FiO2, as well as increase the FRC and expiratory lung volume by providing certain degree of end expiratory positive pressure. Right. So can you elaborate, Srishti, how do we actually, initiate HFNO therapy and titrate the therapy further in a case of acute hypoxemic respiratory failure?
So in HFNO, we need to set three parameters: fraction of inspired oxygen, total flow, and the temperature.
You can move the slide also, it will help
Yes,
the
sir.
audience as well.
Yes, sir.
Yeah.
Here we can see that the fraction of inspired oxygen we can set here, the total flow, and the temperature. Since here in our case the patient is hypoxemic, we are using a high flow, that is 60 liters per minute. Moderate flow such as 20 to 40 liters per minute can be used for normosemic patients with high work of breathing to reduce the work of breathing. In pediatric patients, we can keep the flow of 2 liters per minute per kg body weight, which should not exceed more than 10 liters per minute in infants and 12 to 15 liters per minute in older children. HFNC also applies a PEEP of about 0.57 centimeter of water per 10 liter of flow with closed mouth and half of that with open mouth. We can titrate the fraction of inspired oxygen to the SpO2 of the patient.
Right. So, as we already discussed, flow and FiO2, both these components you can titrate. The FiO2 can be titrated to the desired SpO2, and the flow can be titrated to the work of breathing or the respiratory rate. And this is one of the scenarios where you should always ask your patient to close the mouth and breathe, so that there can be better oxygenation. Now, there are few clinical questions we need to address here. Before the advent of HFNO, in such cases with severe hypoxia, we have already seen the PaO to FiO2 ratio was about 60. So I would have straight away intubated these patients and put on mechanical ventilation, or a trial of NIV could have been given. So I would like to come to Anirban to clarify certain doubts regarding use of HFNO versus use of NIV in certain situations, number one. And number two, when do you consider upfront intubation or intubation after a period of observation when you put the patient on HFNO?
Thank you, sir. So, as we can see, in patients with acute hypoxemic respiratory failure, physiologically speaking, they do not have a ventilation failure. In this patient also, his PaCO2 before we put him on HFNC was 32. So he was anyways hyperventilating, and to compensate. So these are probably the kind of patients who would benefit more with HFNC. HFNC gives you a very warm and humidified oxygen at a very high flow rate. You can maintain the FiO2 as well, and this becomes much more comfortable for the patients. Whereas on NIV, patients are hooked onto an oronasal mask, they may be claustrophobic, and they really do not need ventilation support at that point. So from a logical point of view, HFNC seems to be better in a patient with acute hypoxemic respiratory failure. Oftentimes during COVID, what we did was we awake prone those patients. So HFNC is much better applied in those patients. You can prone those patients easily with HFNC rather than on an NIV mask. So from a logistic point of view and from physiological point of view, definitely HFNC seems to be more advantageous. Coming to the studies, the Florali trial came to be in 2015, which was in multi-center open label trial. So what they did is they randomized around 300 patients with acute hypoxemic respiratory failure without any hypercapnia into three arms, roughly 100 in each arms. 100 of the patients received conventional oxygen therapy. One group has received HFNC and one group has received NIV. And they looked at the primary outcome of intubation rate at day 28. So overall, if you look at it, there is no difference between HFNC and NIV. But if you look at the 90-day mortality, which is secondary outcome, it was better with HFNC. Also, the HFNC reduced the intubation rate in the patients who were sicker, who had a PaO2 FiO2 ratio less than 200. So, this gives us an early suggestion that probably HFNC would be a better non-invasive respiratory support in patients with acute hypoxemic respiratory failure. This has been reiterated in the ERS clinical practice guidelines, where they have mentioned that the use of HFNC has been suggested over NIV in patients with acute hypoxemic respiratory failure. Although the certainty of evidence is very low, and we still have just a Florali trial with a good secondary outcome benefit. Next. Yes. So regarding whether we should straight away go for intubation or we still have some time to try out non-invasive respiratory support. So what happens in ARDS is that what we typically do is, unless the patient is has developed shock and is a high risk of developing a impending cardiorespiratory arrest or something, we typically give them a trial of non-invasive respiratory support, and then continuously monitor the patient bedside for improvement or deterioration. So the frequency of monitoring, the intensity of monitoring, and the threshold of intubating is decided by the initial PaO2 FiO2 ratio. So for example, if somebody comes with a PaO2 FiO2 ratio of 50, we are going to probably give him a brief HFNC or NIV trial while preparing for intubation, and see if there is any improvement. If there is good improvement, we might as well continue. If there is no improvement, we'll intubate. Vis-a-vis a patient who has a PaO2 FiO2 ratio of 200. So our frequency of, we may be a bit more relaxed, so we might put them on HFNC and try out for 1 hour or 2 hours and see our clinical improvement, or the use of objective criteria like ROX index. Typically, we should not use these indices in isolation. We should look at the entire clinical picture, and we can take the decision. So basically, our frequency and our threshold of intubation depends on the initial severity of sickness of this.
Right. So to give some thumb rule for our PGs, in type 1, that is acute hypoxemic respiratory failure, initial non-invasive support of our choice is HFNO. And in case of type 2 respiratory failure, where hypercarbia is there as well, you may choose initially non-invasive ventilation. And another important consideration over here is that once you have put the patient of HFNO, as Anirban specifically emphasized, frequent monitoring is very, very important, and it's very important to early identify the cohort of patients who are going to get intubated subsequently. Because if you see the data from Florali trial and other subsequent studies, the cohort of patients who had a delayed intubation after a significant period of trial of HFNC, they had much higher mortality compared to the cohort who were intubated upfront. So that means HFNC should not be used as a modality to delay intubation. Rather than it's important to identify HFNO non-responder versus responders quite early, within initial few hours, maybe by 2 hours preferably, and then decide on the subsequent course of action. So that's why ROX index provide a good objective criteria over and above our clinical judgment to identify the patients who are likely to get intubated. Well, so let us move ahead and see what happened to these patients after putting on HFNO.
HFNO at 60 liters per minute at FiO2 of 1. We could see that there was deterioration of the PF ratio. The blood gas analysis revealed partial pressure of oxygen, which decreased to 60 millimeters of mercury. The respiratory rate continued to be 35 breaths per minute, and the saturation was 88 to 90%. The ROX index at this point was 2.51 even after 2 hours. So the decision was taken to intubate the patient, and the patient was electively ventilated with ventilatory settings being VCV mode, where the tidal volume delivered was 300 ml and the respiratory rate set was 25 breaths per minute.
Right. So, Srishti, let us discuss a bit about intubation of this patient.
Yes, sir.
So we can see that even on HFNO, the PF ratio was 60 only. PO2 of 60 on FiO2 of 1, and you rightly, and the ROX index was only 2.51. So you rightly decided on intubation of this patient. So how I would like to know from you, how do you decide on the ventilation strategy, the initial ventilation strategy of these patients?
Sir, the goals of our ventilation should be where the plateau pressure should be less than 30 centimeters of water, and maintaining this, we can keep the tidal volume of about 6 to 8 ml per kg. The oxygenation goal of our ventilation should be 55 to 80 millimeters of mercury, maintaining a saturation of 88 to 95%. And the pH to be maintained as 7.3 to 7.45. Initially, we are going to ventilate the patient with 6 ml per kg of ideal body weight, which totals of 300 ml. Then we can calculate the plateau pressure by end inspiratory hold and see if the plateau pressure is less than 30 centimeters of water or not. If it is more than 30 centimeters of water, then we can decrease the tidal volume by 1 ml per kg. And we also need to do frequent blood gas analysis to estimate the partial pressure of carbon dioxide so as to set the respiratory rate accordingly.
Right. So, grossly, the components of a typical volume control mode that we usually use most commonly in ARDS patients are tidal volume, respiratory rate, FiO2, and PEEP, and I ratio, right? These are the usual settings. So, you can move ahead with the slides so that audience can connect. Yeah. So, for oxygenation, typically we set FiO2 and PEEP, and for ventilation we set up tidal volume and respiratory rate, right? So the FiO2 and PEEP are usually set up with the original ARDS net PEEP FiO2 table. So you can see there are low PEEP higher FiO2 and high PEEP low FiO2 table. So from that table, conventionally, one can take the help of this table and choose the FiO2 PEEP combination with a target PO2 of, as you said, 55 to 80, or in target SPO2 of 88 to 95%. Whereas for ventilation, we set a tidal volume as well as the respiratory rate. Now, tidal volume should be set by as per the predicted body weight, and predicted body weight is calculated based on heights in males and females separately. We have separate formulas for that, right? And 6 ml per kg is the usual go-to tidal volume. And whenever you set a tidal volume, the safety parameter that you need to check is the plateau pressures, right? And we try to maintain our plateau pressure goal to less than 30. As ARDS patients will have a very low compliance, stiff lung, plateau pressures is going to rise. And we try to check our tidal volume 6 ml per kg or even less if required, if the plateau pressure is going above 30. And as you rightly mentioned, the plateau pressure should be intermittently monitored in the screen, or you can do it continuously also in many ventilators by applying the inspiratory pause. And the respiratory rate should be titrated to achieve a minute ventilation, which will prevent hypercarbic acidosis, that is any respiratory acidosis, and we need to maintain the pH goal for that, okay, which should be ideally more than 7.3. You can move ahead with the slides. Yes. So the typically as per ARDS net, the highest respiratory rate can be up to 35, and you titrate to a pH goal rather than a specific PaCO2 goal. Okay. So at this point, this is general idea about our initial ventilation strategy. Now, for intubation, you would have used a muscle relaxant as well as the sedative hypnotic agents, right? So moving ahead, would you like to use muscle relaxant continuously in this patient, Srishti?
Sir, since we have intubated the patient, we can give initial 48 hours of this atracurium infusion. As the patient's PF ratio was deteriorating, we need If we continue the neuromuscular blocker infusion, we know that it will improve the oxygenation of the patient and decrease the patient ventilator asynchrony.
Right. So these are the advantages of using neuromuscular blockades. We'll discuss about them in detail. So before that, let us see what happens with the next course of events.
Yes, sir. After 1 hour of invasive ventilation, the patient's vitals were within the normal limit and the saturation was 90%. Blood gas analysis revealed the partial pressure of oxygen to be 74 millimeters of mercury and that of carbon dioxide was 45 millimeters of mercury. Cisatracurium infusion was started at 7.2 milligram per hour and the decision to prone the patient was taken.
Right. So, since even after conventional ventilation with lung protective strategy, the PF ratio was barely 74, right? So
Yes,
that's a
sir.
rate to prone, which is a right decision at this moment. Now, here I would like to come to Anirban again for certain clarifications. Srishti has rightly pointed out the advantages of neuromuscular blockades like reduction, patient ventilator asynchronies, and reduction in the work of breathing. So, can you throw some more light on this, particularly in terms of use of intermittent versus continuous neuromuscular blockade in association with deep or light sedation? Anirban.
Yes, sir. So as rightly pointed out, what we know for sure is that the use of neuromuscular blockers reduces the asynchrony and probably increases oxygenation as well. However, their effect on the outcome is doubtful. So specifically, there are two large multicenter randomized controlled trials that have been done. So these are the Accuracies trial and the Rose trial. I think Rose trial came in is the latest one, 2018 probably. So they have tested similar strategies in similar group of patients. Both the study included patients with moderate to severe ARDS, and they had tested cisatracurium bolus followed by infusions. However, they had different results. Whereas the Accuracies trial was a positive trial where the primary outcome of adjusted 90-day mortality was significantly lower in the patients who received the 48 hours infusion of cisatracurium. It was not reproduced in the more recent Rose trial, where the primary outcome of in-hospital death was at 90 day was not significantly different. What is notable is that there are differences in the methodology of the trial. So specifically, in Rose trial, the patients in the control group had a much lower sedation target, so they were lightly sedated. Whereas in case of Accuracies trial, the patients who were in the control group were deeply sedated with a much lower, much higher sedation scales. So if we have to take a message out of these two, so what we can infer is that if we can manage our patients of ARDS with light sedation, we do not need to paralyze them. However, if we see these patients are not maintaining oxygenations, lots of asynchrony is going around, and for which we are constantly ramping up our sedation and eventually reaching to a point where we have deeply sedated those patients, we might as well try giving them an brief 48 hours infusion of cisatracurium upfront. Another notable difference is that the Rose trial, only 16% of the patients with moderate to severe ARDS were prone, which is very much inadvisable because all of their patients had a PaO to FiO2 ratio below 150. Now, proning also gives us unique challenges. It's practically, if you look at it, it is much more difficult to prone a patient without neuromuscular paralysis rather than with. So typically what we do is that in those cases, if we are proning early on, then and the patient have severely hit oxygenations, we routinely start cisatracurium infusion and prone those patients. But we do not continue those infusions for too long. The subsequent pronings we often do with intermittent boluses of cisatracurium, and so that we do not continue giving lots and lots of neuromuscular blocker late into the disease. This might lead to complications like myopathies and ICU-acquired weaknesses. There are no trial, to the best of my knowledge, sir, that compares continuous versus intermittent neuromuscular blockade in ARDS. So that might be a research gap for future. And so the take home from this would be that if I am able to manage my patients on light sedation, I will not paralyze them. However, if I am having to give them deep sedation and proning, so I typically would consider giving them cisatracurium infusions.
Right. So, very rightly said. And in this context, although trials have used cisatracurium because of certain advantages of it, mainly the non-organ dependent elimination, but it may not be available and cost may be an issue in many parts of the world. So, if we really have to use any relaxant, we can choose other relaxant as well, depending on the availability, like atracurium or even rocuronium and becuronium. So,
Yes,
not that we have to use cis-atracurium only.
that's correct, sir.
Right. Although there are some, I think, anti-inflammatory property of cis-atracurium as well, which have been highlighted in previous studies.
So animal studies have used cisatracurium and pancuronium. They've demonstrated inflammatory effects in these two molecules. However, it's hard to say the other molecules will not have that. We do not know that.
Right. Okay, so far we have discussed about the basic conventional ventilation, including lung productive ventilation with the use of low tidal volume, and a little bit about the use of muscle relaxation. So moving ahead, Srishti, yes, we have some MCQs for the audience. If you can read it out.
Yes, sir. Which of the following ventilator settings is most closely associated with mortality benefit in ARDS patients? Option A, low tidal volume. Option B, high PEEP. Option C, low plateau pressure. And option D, low driving pressure.
So audiences can, yeah. So we are already getting answers. A, C, and D, the mix of answers. I guess both A and D can be considered right options here. These two have been shown to be associated with mortality benefit, low tidal volume as well as low driving pressures. And move ahead, Srishti. So next, yeah.
Next question. What is the goal of mechanical ventilation in ARDS? Option A, to prevent hypoxemia. Option B, to prevent ventilation-induced lung injury. Option C, to reduce driving pressure. Option D, to reduce work-off breathing. And option E, all of the above.
Yes, this seems to be an easy MCQ. So all of the above are the right answers. But overall, if you think about the basic philosophy of ARDS ventilation, to prevent VILI is our most important concern here.
Yes.
Because we should not do more harm to the patients. So this brings us to the discussion of ventilator-induced lung injury. So, which is a first and foremost concern for us when we are ventilating a patient of ARDS. So, I would just like Anirban to quickly have a few words on the types of ventilator-induced lung injury. Then we can move ahead with the further discussion.
So this is a famous article published in NEJM 2013. So I would request all the postgraduate trainees to at least go through this article and the Berlin definition article. So these are very important articles for ARDS. So yes, what we have seen is that ventilation-induced lung injury has become very much a part of the pathophysiology and disease mechanisms in ARDS. So that is that some part of ARDS morbidity and mortality is related to inappropriate ventilation. So how does that happen? So it happens because we are giving positive pressure ventilations and we are distending the alveoli which are inflamed. So this leads to volute trauma, where because of over distension of some alveoli, there are inflammatory processes that start specifically because of that. Barotrauma and volute trauma are the two sides of the same coins. Those alveoli are subjected to high transpulmonary pressures, high volumes, and therefore they get injured. Atelectroma is, on the other hand, is that if we are not ventilating these patients well with optimal PEEP, so they tend to undergo cyclical opening and collapse with each respiratory cycle. So as they open and close, there is some friction going on, and there is a release of inflammatory mediators because of cyclical opening and closing of those alveoli. So this is what we know as atelectroma. So there are bits of volute trauma going in one part of the lungs, whereas atelectroma going in one part of the lungs, because ARDS is a heterogeneous condition. So all of them together contribute to ventilation-induced lung injury. Biotrauma is when those inflammatory mediators are released and they get spilled over into the circulations as well. So there is a sort of dictum that ARDS patients never die of hypoxemia, they die of organ failures. So that is the reason our inappropriate ventilation might lead to spillage of more and more inflammatory mediators, and other organ failures as well. So the effect of ventilation is not restricted to just lung injuries and may propagate other organ injuries as well. So this is what we mean by ventilation induced lung injury.
Right.
So naturally we should find ways of reducing ventilation induced lung injury. How we can do that? So this was probably one of the most important article of this millennium, where there has been an overnight shift in the strategy of ventilating ARDS patients. Before, we were ventilating the ARDS patients with a very high tidal volume, and after that, after the publication of this study, which has compared a tidal volume 6 ml per kg versus 12 ml per kg, and they have found a huge mortality difference, we have overnight shifted our strategy to a low tidal volume ventilation. So if there is one thing that you have to do for your ARDS patient, that would be low tidal volume ventilation. Next.
Right. So low tidal volume is almost clear that we need to stick to 6 ml per kg of criteria and limit our plateau pressures, as well as try to limit our driving pressures as well. So we'll discuss more about driving pressure. Before that, one of the most controversial aspects is the setting of PEEP. So although we have some initial guidance by the ARDS net trial on low and high PEEP with FiO2 tables, but it gets confusing many times, and there have been a lot of discussions, debates, and trials which try to find out an optimal PEEP. So what should be our take on this low PEEP versus high PEEP? You can just explain, Anirban.
So if you look at the ARDS net protocol, they give us two PEEP FiO2 tables. So there is a higher PEEP FiO2 table and there is a lower PEEP FiO2 table. So which one do we need to select? So there have been three large RCTs, the Alveoli Express and Love's trial, and a meta-analysis that combines their results. Overall, what we have found out that in a group of ARDS patients where we do not stratify them as per severity, there has not been much difference in outcome whether we adopt the high PEEP FiO2 or low PEEP FiO2. But if we look at the sicker patients with a PaO to FiO2 ratio below 200, the patients who received higher PEEP fared better. So how we can translate this to our practice? If we have a patient who is extremely sick, very low PaO to FiO2 ratio, better stick to the higher PEEP FiO2 table. And as the patient improves or patient has mild ARDS, probably lower PEEP FiO2 table can be initiated, or we can shift our strategy to a lower PEEP FiO2 table while weaning those patients or coming down on the FiO2 and PEEP. So
Right.
that is something that we can adopt.
Right. So when we discuss about PEEP, setting of PEEP, and already we have talked about plateau pressure targets. So this brings to an interesting concept of driving pressure, which have come in the last decade. So Srishti, can you tell us what is the driving pressure?
The driving pressure is calculated by subtracting PEEP from the plateau pressure, and we need to titrate our PEEP and plateau pressure so as to maintain a driving pressure of less than 17 centimeters of water.
Yes, so Anirban, your comments on this, specifically this wonderful study by Amato et al., which have given us the concept of how driving pressure is linked to survival outcomes.
Yes. So this study was a secondary analysis of the major ARDS trials. So what they have taken individual patient level data and they have done a secondary analysis. What they found is the driving pressure is the parameter that is most closely related to mortality. So they have found that even in the low tidal volume versus high tidal volume and the low PEEP versus high PEEP, and if they've clubbed together in quantiles of increasing driving pressure, the mortality was increasing, irrespective of what the PEEP or the tidal volume were for those patients. So this brings us to the concept of an individualized ventilation. So what is driving pressure specifically is that when we talk of 6 ml per kg, we do not pay regard to what is the compliance of the patient's lung and what is the amount of the lung that remains aerated in an ARDS patients. So we have to link to this so-called baby lung. So how we can do that? We have how to get an idea of what is the volume of that baby lung. We have to relate this tidal volume to a pressure marker. So that is the driving pressures. So if you have a very small baby lung with a tidal volume of 6 ml per kg, your driving pressure is going to be very high. So now you do not, even a tidal volume of 6 ml per kg may be harmful for that patient. So a more closer to patient's actual respiratory mechanics is the driving pressure. So what we should do in our clinical practice is we should monitor the driving pressure and we should keep it somewhere between 12 to 15. So if you look at the chart here, beyond driving pressure of 15, the odds relative risk of death is beyond 1. So that is where it comes from. The 12 to 15 is the target of driving pressure. So we look at our tidal volume, we look at our plateau pressures, and we also look at our driving pressures after the publication of this secondary analysis.
Yes, absolutely. So the message is that irrespective of the tidal volume and the PEEP setup, driving pressure individually can be linked to adverse outcome in terms of mortality. So always we should measure the driving pressure of the patient and titrate our PEEP and tidal volume accordingly. We try to limit our tidal volume to 6, or if required, in the face of a higher driving pressure, we can go down further in the tidal volume. And PEEP, which is kind of an arbitrary concept, high PEEP versus low PEEP, to accurately find out the PEEP and driving pressure can be a good guide. So this brings to our next part of discussion, how to set up a PEEP. Basically, we already talked about higher PEEP may be better or lower PEEP may be better in different cohorts of patients, but how to exactly decide what will be the exact PEEP for a given patient in a given condition. So let us start with an MCQ here. Srishti, if you can read out.
Question: which is the best method of PEEP titration? Option A, PEEP and FiO2 table. Option B, ascending PEEP titration. Option C, esophageal pressure monitoring. Option D, stress index. And option E, none is superior.
Yes, you can put your answers in the chat box. So we have already discussed about PEEP FiO2 table among these options. We have not discussed the other ones. There are n number of ways of setting up of a PEEP in a patient of ARDS. So we have mostly answers A and B so far. So let us discuss a little bit about the other methods mentioned, like ascending or descending PEEP titration and transpulmonary pressure and stress index quickly. These are a bit difficult concepts for the anesthesiology PG. So I will try to request Anirban to be a bit brief and quick also. So Anirban, can you please explain the methods?
Yeah. So before that, let us imagine what an ARDS lung is. So in ARDS lung, there will be areas which will collapse with each breath. So these are the recruitable areas. Okay, the alveoli are going to collapse with each breath, and there are areas which are over distended. Areas of the lungs which are non-dependent. So they are already over distended. So a PEEP strategy that will just about prevent the alveoli which are lower down from undergoing cyclical opening and collapse, while preventing over distension in the non-dependent region is the best PEEP. So how we can find it? So for that, what we can do it, we can do some kind of PEEP titration. So in PEEP titration, typically what we do is, can we go to the next slide? So 16, next slide. Yes. So what we typically do, for example, we start with a PEEP of 8 centimeter of water. And what we do is we increase the PEEP in increments of 2. So we go up to a PEEP of 10 while looking at our plateau pressures, our driving pressures, and our oxygenation parameters as well. And another thing that we should also look while doing PEEP titration is our hemodynamics. Because as you know, if we keep on increasing the PEEP, now hemodynamics might get hit at some point. So what we have seen here is that after we bring the PEEP up to 10 centimeter of water and we ventilate for 2 minutes, and we see that our driving pressure is somewhat reduced. From 20 it has become 19. So this gives us reassurance that we can further increase the PEEP to see what happens. Right, your SpO2 has not changed. It is 90%, and it has been 19% after 10 centimeter water as well. So we go to a 12 centimeter water PEEP and again ventilate for around 2 minutes and see that our driving pressure remains the same. However, oxygenation somewhat improved, SpO2 of 1%. And after that, we further increase the PEEP to 14. We see driving pressure remains 19. SpO2 has increased to 92%, well and good up till this point. But when we increase our PEEP to 16, we see that there is a sharp overshoot of driving pressure. So driving pressure suddenly overshot. So why is that happening? Probably now is the point where we have started over distending the alveoli. So what we do is we come down to the lower step, and that is probably the best PEEP for these patients. Now in this, we also have to pay regards to the hemodynamics. At any point, if there is hemodynamic instability, we may not be able to give this PEEP as well. So the best PEEP is something which depends on a lot of factors: the oxygenation, the driving pressure, as well as the hemodynamics. Now, for example, in this patient, we have given our best PEEP, we have come down on tidal, we have given our best PEEP, and still your driving pressure is more than 17. So our target is below that. So what we can do to reduce the driving pressure? So we can come down on the tidal volume if PaCO2 and pH allows. So if your PaCO2 is already beyond 60, pH is already 7.15, we cannot come down on tidal volume, and that is when we should think about doing some other strategies, like we can discuss putting extracorporeal therapies, or we should prone these patients to see if the driving pressure improves or not.
Right. So regarding other methods, like stress index can be a quick assessment, although it's difficult to calculate. So Anirban, your thoughts on this?
Sir, stress index, it is difficult to calculate. We never calculate in our day-to-day practice. What thumb rule we apply is that if you, Srishti, can you show the ascending pressure scalar, ascending part of the pressure scalar? So this is the ascending part of the pressure scalar. So there are 3 scenarios. One is that it is completely straight, right? So that is stress index of 1. But if there is a upward concavity, you can see there is upward beaking, that concavity. Okay. So that indicates the stress index is more than 1. What it indicates is there are some areas of lung which are getting over distended, right? So if there is a downward shift, downward fall of the ascending pressure part of the pressure scalar, that means stress index is below 1, which indicates a safer ventilation strategy. So we might also look at our shape of the pressure scalar, and we should avoid an upward beaking of the pressure scalar.
Right. And about transpulmonary or esophageal pressure in our clinical practice?
So the concept of transpulmonary pressure is that while our airway pressures may not reflect actual transpulmonary pressure. So what is transpulmonary pressure? So that is the alveolar pressure minus the pleural pressure. So that is the actual distending pressure of your alveoli. Okay, we are using airway pressures as surrogates because we cannot always measure transpulmonary pressures. In most of our patients, probably your airway pressures are going to do a reasonably good job of approximating transpulmonary pressures. Things become difficult in patients who are obese or patients have intra-abdominal hypertension, where your pleural pressures may start rising, and that is where your transpulmonary pressure may not be accurately adjudged by your airway pressures. These are the areas where we can still consider using transpulmonary pressure guided ventilation, where what we do is that we do not allow the transpulmonary pressure to become negative at end expiration, so that there is no collapse of the alveoli. So if the transpulmonary pressure becomes zero, there will be collapse of the alveoli, right? Because alveolar volume will not be there. So we keep it positive at end expiration. And to limit this over distension, we do not go beyond a transpulmonary pressure of 10 to 12 in the inspiratory cycle. Okay, so this is what we do. But if you look at the trials in a heterogeneous group of ARDS patients, they did not translate into any benefit of outcomes. So even if we consider doing that, we need to choose our patients. Doing that routinely in all our patients is not the way to be. If sometimes you have a huge morbidly obese patients and patients who are having intra-abdominal hypertension, we might as well consider also, although this is probably, I feel that is a research gap where we can test this strategy in those specific groups of patient, whether it really
Absolutely.
translates to benefit or not.
Absolutely. So we have reasonably discussed most of our approaches to lung mechanics and ventilation strategies. But one important consideration here is that to limit our tidal volume, plateau pressures, driving pressures, we always face the risk of respiratory acidosis and hypercapnia, as you have already mentioned. So there should be some consideration or limit to our approach to this permissive hypercapnia and its consequences. So, can you elaborate a bit on this, Anirban?
So, if you look at ARDS net protocol, they would want you to do permissive hypercapnia up till a point where the pH is not below 7.2. So, initial idea about permissive hypercapnia was that it is a benign sort of accompaniment of ventilating ARDS patients. However, we have lately realized that it is associated with other organ side effects as well. So, there is cerebral vasodilation, then pulmonary vascular resistance increases, and there is decreased renal blood flow, and that might propagate your acute kidney injuries. Most importantly, about 25% of your patients of severe ARDS might also have an associated acute right ventricular failure. So by allowing permissive hypercapnia, we might be propagating the acute right ventricular failure and shock in those patients. So therefore, permissive hypercapnia is something that, if given a chance, we should try maintaining normocapnia and never go beyond 60 centimeter of water of PaCO2. Before, we never had a choice, but right now, as the ECMO is becoming popular, so probably if we are, if we are unable to maintain a lung protective strategy because of PaCO2 going overboard, so we might consider those patients to be good ECMO candidates as well.
Right. So it's difficult to maintain a normal PaCO2 in these kind of patients, and we have to accept some form of hypercapnia. But always we should look for the RV function in these patients. The message is that in your severe ARDS patients on ventilation, if you find the patient is developing shock on maybe day 2, which was not initially there, always do a echo and find out what is happening to the RV. So you should never miss that, because your management strategy is going to change accordingly. Now, moving ahead, let us come to the case discussion again. We had prone this patient, right, Srishti? What happened afterwards?
Yes, sir. Sir, after 2 hours of proning, the saturation improved to 98% on FiO2 of 0.8. Blood gas analysis revealed partial pressure of oxygen as 100 millimeters of mercury, and that of carbon dioxide was 45 millimeters of mercury.
So as you can see, patient has probably responded to prone, right? The PaO2 is 100 on FiO2 of 0.8. That means PF ratio is about 125. Initially, we started about 60 PF ratio. So it's important to identify the prone responders. So how do you classify prone responders, Srishti?
So, PaO2 responders are those whose PF ratio increases by at least 20% or by more than equal to 20 millimeters of mercury. And PaCO2 responders are those whose PaCO2 decreases by more than equal to 1 millimeters of mercury.
Right. So, why do you think the patient responded to prone ventilation? Like, what are the advantages or mechanisms by which prone ventilation helped in this patient, Srishti?
So, prone position helps in homogeneous distribution of the ventilation and enhances better ventilation perfusion matching. Also, the dorsal alveoli are aerated better, and there is relief of the mediastinal compression, which improves the lymphatic clearance.
Right.
Prone
So,
position,
you
yes,
can
sir.
go ahead with the slides. So, the
Yes,
with
sir.
diagrams, the students will understand it better. Yes. So, you have rightly pointed out all the points. Anirban, can you quickly explain this point for the students and then we can move ahead?
Yes, so this might be a bit hard to grasp, but I'll try to make it simple. What you can see, there is a square and there is a triangle, right? So this triangle is the lungs. So if you imagine a hemithorax, so the shape of an hemithorax would be roughly like a square, and inside that hemithorax is a triangular lung, right? So, but there is vacuum between a hemithorax and a lung. So this lung gets stretched. So what happens is the alveoli, which are in the front, in the anterior alveoli, so these are getting more stretched because the number of alveoli in this region is less to accommodate this entire space. Whereas there are more alveoli in the posterior lung segments. So they will be relatively less distended already, because to match the shape, because there are many alveoli which are being accommodated in those areas, right? So this is called shape matching. So because of this shape matching, the anterior alveoli are bigger than the posterior alveoli. Now what happens in ARDS is a gravity component also comes, because lungs becomes wetter and becomes heavier. So the anterior lung, once the weight of those lungs starts increasing, they would compress the posterior lungs further. So now the already less distended posterior lungs are going to get even lesser volumes, right? So this brings about a heterogeneity in ARDS lungs, where the anterior lungs are more distended compared to the posterior lungs. Now, once we prone this patient, the effect of gravity is altered. So now what happens, although the shape matching does not change, because of the shape matching, the lung which is anterior is going to be more distended, but the gravity effect gets altered. So now the weight of the posterior lung segment falls on the anterior. So the effect of gravity is now somewhat countering the effect of shape matching and thereby homogenizing the alveoli gas distribution. Okay, so this is a concept. You can always go back to this article and read it. It's a wonderful article. So they have described all the mechanisms by which proning works. Next. However, the most important reason why proning works is because majority of our alveoli are in our posterior segment. So if you prone these patients, those alveoli get better. So if you imagine this triangle to be the lung, 75% of the alveoli are posterior and 25% are anterior. So if you prone these patients, the ventilation to those 75% of the alveoli increases. So more and more alveoli are getting better ventilation once we prone. So this is probably the reason why oxygenation is getting better. Next. Also, if you look at these two CT images, the weight of the mediastinum is relieved from these lung areas, which are marked in green, and therefore leads to opening up of these lung areas once the patient is in prone position. Secondly, with your mediastinum, which is now dependent over underneath your lungs, the lymphatic clearance from the lungs onto those mediastinum also improves. So therefore, clearing of exudation would theoretically be better in a prone position. So these are several mechanisms by which proning works. The most important is that the one that we have to realize is that proning homogenizes the gas distribution, therefore homogenizes the distribution of injurious mechanical power to the lungs, and thereby reduces ventilation induced lung injury. And this is the reason why we found outcome benefit with proning as an upfront strategy in ARDS patients. So proning is not a rescue strategy. It is an upfront lung protective strategy that should be instituted with anyone having severe ARDS.
Absolutely. So we have this important PROSEVA trial which demonstrates substantial mortality benefit in terms of prone ventilation, 16% in the prone group versus 32%. There will be very few trials in the history of critical care which leads to almost 50% relative risk reduction of mortality with the use of a strategy. So that's why, as Anirban rightly pointed out, prone has been considered a kind of a rescue strategy before the PROSEVA trial, but after 2014 of this trial, and subsequently prone was popularized during the COVID pandemic. Now we should consider, and all of us consider, prone ventilation upfront in severe ARDS patients, maybe within 1 or 2 hours after intubation, conventional lung protective ventilation, and other maneuvers like PEEP titration and etc. If the patient doesn't respond, we directly move ahead with the prone position. So as per PROSEVA trial, we consider proning in PF ratio of less than 150 in patients with PF ratio of less than 150. This is important after optimal ventilation strategy. And another important point to consider is that we prone them for at least, try to prone them at least for 12 hours, preferably 16 hours at least in a day. So as per PROSEVA trial, 16 hours is required consecutively proning, and each day you keep on giving the sessions as long as patient gets better. So the idea is to identify the prone responders quickly and continue with prone therapy. But having said that, for the ICUs which are not performing prone so far, need some bit of training and their own protocol for development of prone strategies. And we need to select our patients carefully. Initially, we used to have a long list of contraindications for prone therapy. Nowadays, the list is getting shorter. So let us move ahead, Srishti, and see how our students answer this question.
Question is, what is an absolute contraindication to proning? Option A, hemodynamic instability. Option B, pregnancy. Option C, raised intracranial pressure. Option D, unstable spinal fracture.
Right. Yeah, all the answers we can see are right answers. So Anirban, your thoughts on this?
So as sir, you have said, the list of contraindications are coming, becoming smaller day by day. So we are now proning patients who are hemodynamically unstable. Even on dual vasopressors, many a times we prone this patient if the PF ratio is very less. And the list of contraindication will only come down if we get more and more experience with the procedure. So if your center is newly adopting this policy, then you might be a little more careful. But after you do around 20 sessions of proning, 50 sessions of proning, you would be more confident in proning any patients who are hemodynamically unstable. So lately we have started proning the pregnant women also, that was done during COVID pandemic, where we put lots of pillows so that to keep the abdomen free, and we prone pregnant ladies as well. And patients with polytrauma often develop traumatic ARDS. Sometimes if they develop severe ARDS, we have to do a balancing act between raising the ICP or creating cerebral hypoxia, because anyways, if you do not maintain a blood oxygenation, you are going to eventually lead to secondary brain insult. So these have become sort of relative contraindications. The only absolute contraindication that remains is an unstable spine.
Yes. So it's important to train our staff, the nursing and other staff in the ICU as well on proning. And we should use our own protocols and checklists, which are mandatory. Certain prerequisites should be ticked. For example, if you have to put any lines and catheters, do some investigations, echo, POCUS, and all those things, try to do it just before proning and move ahead. There are various literatures are available on proning, and I request all the students to go through them and learn this, because this is the single most important factor which improves survival in ARDS. So it's very, very important that ICUs adopt proning practices at the earliest, and explore further in this line to provide maximal benefit to majority of the patients. So let us move ahead and see what happened to this patients. He already responded to proning. Next, Srishti.
The patient received furosemide injection 20 milligrams stat in the ER and nebulization with 2 duolin respules in the ER. The antibiotics which were given were injection amoxicillin plus clavulanate 1.2 gram IV TDS and injection azithromycin 1 gram IV OD. Antiviral tab oseltamivir was given 75 milligram RT BD. The sedation was continued with fentanyl 100 microgram per hour, and for strep ulcer prophylaxis, injection pantoprazole was given 40 milligram IV OD. For DVT prophylaxis, injection enoxaparin 40 milligram subcutaneous ODHS was continued. Nutritional therapy, trophic RT feeding was started from day 1, about 840 kilocalories, and from day 2, it was increased to 1400 kilocalories. Patient received injection paracetamol 1 gram IV TDS.
Right. So, in this context, a couple of things like although Duolin was used in the ER, in the absence of a obstructive airway disease, we should refrain from using beta 2 agonists in this ARDS patients, because they really do not provide much benefit and even may cause harm in certain conditions, and there are some data to support that. So, routine beta 2 agonist like salbutamol or Duolin should not be administered. And oseltamivir is a drug of choice when you suspect a ARDS because of a viral underlying pathology, be it H1N1 or mainly in H1N1 or other influenza viruses. But interestingly, important point to note here is the fluid administration here. Yes, and one more thing regarding the nutrition. Initially, when prone therapies were being started, there were a lot of apprehension about continuing feeding in prone position, but there are no issues. You can start feeding and continue to feed patients in prone position, particularly the trophic feeds. It's just that you need to be careful about the amount of feed being given, and slight reverse channel bug or head up tilt in prone position will help in feeding. Now, regarding the fluid strategy in these patients, in the absence of shock in ARDS patient, there can be some debate about conservative versus liberal fluid administration strategies. So, Anirban, your thoughts on this?
Sir, this is a study that was published, the FACT trial. So what they have found is that use of a conservative fluid strategy was associated with a better oxygenation and increased ventilator free days. And this is more so in patients who have extrapulmonary ARDS. So they're conservative. I mean, in pulmonary ARDS, where conservative fluid management is better. And this is one thing that we often forget in our ARDS patients. So our cumulative fluid balance keeps on increasing by day 7 we have around 3 liter, 4 liter, 5 liters cumulative fluid mass. So if there is one aspect of fast heartbeats that we should be careful about in ARDS patient, that would be our fluid. So we should be very stingy with our fluid if our patients are hemodynamically stable.
Yes. So the conservative fluid management means basically you're targeting a neutral fluid balance, not a positive fluid balance. The concerns are if you are giving too low fluid, the concerns are patient may develop hypotension, patient may develop AKI because of hypovolemia. But the FACT trial has demonstrated that there is no such phenomena occurring, and patients can easily continue on conservative fluid balance. It improves oxygenation and ventilator free days, although it does not affect the mortality per se. Right. So moving ahead, what happens to the patient, Srishti?
So the investigations, we ordered a chest X-ray. Here we can see this is a AP view of chest X-ray, which is well centralized. Trachea is in central position with adequate exposure and no obvious bony or soft tissue abnormality seen. No obvious cardiomegaly or altered cardiothoracic ratios seen. In the lung fields, we can see bilateral patchy parenchymal infiltrates. Blood investigations were almost within the normal limit, where here the interesting point is the total count is just above the lower limit, and the neutrophil is 50% and the lymphocytes were 46%. We sent blood for H1N1 RT-PCR, malaria antigen, scrub typhus, dengue, leptospirosis, and blood and urine culture. The daily vital trends in ICU. On day 1, patient could maintain a saturation of 90% on an FiO2 of 100%. The PF ratio was 140 and the ventilator settings was adjusted to VCV mode with a PEEP of 22 centimeter of water delivering a tidal volume of 325 ml. On day 2, the patient could maintain a saturation of 98% on an FiO2 of 80%, maintaining a PF ratio of 165 on a PEEP of 18 centimeter of water and a tidal volume of 325 ml. On day 3, patient could maintain a saturation of 98% on an FiO2 of 60%, achieving a PF ratio of 200 with a PEEP of 14 centimeter of water and a tidal volume of 325 ml. So the patient received 3 sessions of proning from day 1 to 3, and the initial 48 hours cisatracurium infusion was continued. The infusion was also continued during the time of proning. On day 4, the PF ratio improved to 220 and the patient received first spontaneous awakening or spontaneous breathing trial, but the patient could not be extubated on day 4 due to the persistence of tachypnea. So the patient was kept on PSV on day 4. On day 5, the patient could maintain a saturation of 95% on an FiO2 of 40% with a minimal pressure support of 5 centimeter of water, wherein the patient's respiratory rate was 16 breaths per minute and the patient could maintain a partial pressure of oxygen of 200 millimeters of mercury. So the patient was extubated on day 5.
Right. So thankfully the patient responded to prone positioning. In the absence of this, probably we needed to consider ECMO in an ECMO-enabled center, or early referral to an ECMO-enabled center should be considered. Now, regarding investigations, you rightly pointed out that relative lymphocytosis in the absence of a leukocytosis points in favor of a viral etiology, and which subsequently was found out by a positive H1N1 RT-PCR report. And we had already started on oseltamivir, in association with other supportive and ventilation strategies in ARDS. Now, moving ahead in the last part of our discussion, I would like to highlight one important aspect. So, previously in ARDS patients, recruitment maneuver was a common thing. People used to manually recruit patients when they used to intubate, or intermittently also in the face of a hypoxemia, particularly relative hypoxemia when prone was not commonly being used. Manual or ventilator guided recruitment were being used commonly. So, Anirban, can you elucidate further on this and relative harms and benefits of recruitment maneuver in ARDS patients?
So, in ARDS, patients can either have a recruitable or a non-recruitable lung. So, the idea was proposed that that is called the open lung concept, where we would want to do a recruitment maneuver with very high airway pressures to open up the lungs and keep them open with by maintaining a very high PEEP. So, this is the open lung concept. Now, this open lung approach is associated with some problem that this basically targets the atelectroma part of the ventilation induced lung injury, while but in the process might lead to barotrauma and volutrauma as well. So this was tested in two large multicenter randomized controlled trials, the FARLAP study and the ART trials. So what they have found is that while the FARLAP study there was not much difference, but in ART trial there was significant harm with the use of recruitment maneuvers. Although there were important methodological flaws with, considerations in ART trial, they had exposed the patient to a much higher airway pressures than probably was advisable. But then what message we get is that in the presence of a better strategy of homogenizing the lung and preventing ventilation-induced lung injury, that is proning, that should be preferred over doing a lung recruitment maneuver. Now,
Absolutely.
both these studies were done in a heterogeneous group of ARDS patients. So, that is an area that may be looked at because some of the lungs may be recruitable, some may not be recruitable. So, typically what happens is the lungs which have more of an atelectatic areas compared to consolidations will be recruitable, whereas lungs which have more of consolidations than atelectacy will not be recruitable. Pulmonary ARDS or ARDS with a primary pulmonary insult are usually less recruitable compared to an extrapulmonary ARDS, which are the ARDS associated with sepsis or pancreatitis. So those are more recruitable. So we do not know as of now if we can do some enrichment in the selecting the patient who would benefit with recruitment. So this is another probably future area of research.
Yes, so the path to precision made medicine in ARDS. So these are one of the considerations. Now, what about alternate ventilation strategies like high frequency oscillatory ventilation or APRVs, airway pressure release ventilation, which are used to be used or occasionally being used?
So the high frequency oscillatory ventilation has become very unpopular in adult ARDS after the publication of a RCT in 2013, which has found harm with this procedure in adult ARDS patients. It is still quite popular in some of the pediatric ICUs in pediatric ARDS. And but in the so the downfall of HFO high frequency oscillatory ventilation is because of the publication of because of the suggestion of harm with the procedure, and also the development of better strategy, that is the extracorporeal membrane oxygenations in the last few years. So we do not see much of our ARDS patients getting high frequency oscillatory ventilations. Regarding airway pressure release ventilations, there are benefits that may be there with this ventilation, because we are ventilating the patient at two pressure levels and patients are allowed to spontaneously breathe throughout the ventilation. So this might be there might be requirement of less sedation while maintaining a good mean airway pressure and better oxygenation. So, but the evidence to benefit of with this mode is very limited. I think one positive trial was in 2017. It was a single center RCT, which has shown benefit with the procedure, and it has not been tested adequately. And for the majority of part, we can do well sticking to the conventional ventilation like volume control ventilation rather than adopting a PRV.
Right. So APRV has been an uncommon and a bit labor-intensive strategy to adopt in most of the ICUs, and that's why it's not really that much popular. So we have almost covered most of the important aspects of ARDS ventilation strategies. So lastly, just I would like to I want Anirban to mention a bit about the concept of mechanical power, which Leighton Gattinoni has provided us with a wonderful concept, which our PG should know a bit about.
So we have already discussed barotrauma, volutrauma, and atelectrauma. So in 2016, one of the articles has also coined this term like ergotrauma. So what happens is that now we see ventilation-induced lung injury happening because of transmission of injurious energy or power to the lung from ventilators. So because we are ventilating the patient with positive pressure ventilations. So what is a power? It is the individual. This is a very complicated formula. We don't need to remember it, but what we need to remember it is that the contribution of there are contribution individual components to this mechanical power. So tidal volume contributes, the respiratory rate contributes, and the PEEP contributes as well. The maximum contribution is of tidal volume. So if you increase tidal volume by twice, your mechanical power is going to increase by 4 times. Whereas for respiratory rate, the ratio is somewhere around, if you increase it by twice, the power is going to increase by roughly 3, just to give you an idea. Whereas PEEP, if you increase the PEEP by 2, the power is going to increase by 2. So the idea is that we set our ventilatory settings in a manner which is associated with the least power transference from the ventilator to the lungs. Next.
Right. So, apart from the ventilation strategies, in the pharmacological management of ARDS, perhaps only one modality or intervention which have shown some promise, that is corticosteroids. So, should we use corticosteroids in ARDS patients?
So early, like steroid trials in ARDS, what they have had a variable effect on mortality. So overall, there was no differences. However, one thing is for sure that we should not start steroid late. So if you have a patient on ARDS, already 14 days of hypoxemia is there, and that is not the time when you start steroid, and probably it is advisable not to continue steroid beyond that unless in specific cases like in COVID we had to give steroid because of differences in pathophysiology. So one of the positive trial was the DEXA ARDS, where they randomized patients to receiving early dexamethasone versus placebo in around 277 patients, where they have found an improvement in duration of mechanical ventilation and mortality in ARDS patients. And a subsequent meta-analysis that followed found reduction in mortality with the use of corticosteroids. However, the total number of patients who were included in these randomized trials were less, and probably this is an area which needs further research. One thing is for sure, and that is something which is the most important to be remembered, is that we should not give steroid to H1N1 ARDS. The use of steroid in H1N1 ARDS was found with increased harm. So if you are suspecting H1N1, then you probably should not start steroid upfront. Wait for the H1N1 report and this. So in ARDS associated with severe community-acquired pneumonia, in ARDS associated with severe COVID-19, we can go on and start corticosteroid.
Right, and dexamethasone is perhaps the drug of choice in these conditions, as
Yes.
we have used in COVID-19. In community-acquired pneumonia, I think hydrocortisone or dexamethasone may be equally beneficial, or you can go ahead with hydrocortisone as well. And as you rightly pointed out, H1N1 may be considered a contraindication, although there are some debates and discussions on this. But for the PGs, the take home should be, we can consider H1N1 as a contraindication to ARDS. So moving ahead, we have I think one last MCQ for the students. We guess we've already overshooted the time.
The question is, which of the following has most benefit in ARDS patients? Option A, low tidal volume. Option B, high PEEP. Option C, prone position. Option D, ECMO, extracorporeal membrane oxygenation.
Can see a few answers in the chat box. Right.
Yes.
So the answer is right. Prone position. The most benefit in ARDS patient has been found with prone positioning. Right. So I guess that brings to the end of this case discussion. So ARDS is a little bit of a difficult topic for anesthesiology postgraduate. So that's why I wanted Anirban to throw some light on most of the topics which are controversial over and above what Srishti has answered. So that's all. Thank you from our side. Any questions in the chat box? No, I don't see any questions, I guess. So either they have understood everything or they did not find it interesting. So I don't really know what has happened.
I think they understood everything, sir. The session was very elaborative and was very useful to the postgraduates, sir.
I hope so. Thank you so much.
It also depends upon how the teacher teaches in the class.
Right,
That is
sir.
very important. And anyway, I think most of the queries were being answered as soon as they were coming to that fore, being covered in the text also and being covered in the MCQs also. So
Right, sir.
before moving forward, let me have certain things to be done. Just wait. So considering the hard efforts put by Dr. Dana Medesar and team, so from ISA National, we are feeling honored to honor you for this endeavor in the class, sir. You being the team leader of this pack and done a wonderful job for this class. Thank you very much, sir, for your efforts.
Thank you so much, sir.
Yeah. And Dr. Anirban, equally, enthusiastic young teacher into the making of a good teacher in the future. A very thankful gesture from ISA side. We are honored to have you as a teacher here. Thank you. And I am feeling proud of it also, being from my second homeland. Thank you very much.
Thank you so much, sir.
Then Srishti, she is equally enthusiastic and I think she prepared well. All the efforts of Dr. Dalim and Dr. Nirvan, making her prepare for the class, and she took almost, and it's a difficult topic for a PG student, if you ask me honestly. Till you complete your senior residency, things don't come to your mind, straight away. It takes a time to understand this topic. She did it wonderfully prepared.
Yes, sir.
And Vinolin, yourself, as well as Haripriya, both, you were good in anchoring the class. Thank you very much. Because the screen coordinators are the lifeline of the class, they take everything in a very good way. Smooth conduct to the class. Thank you, both of you.
Thank you, sir.
And my all thanks go to my class coordinators also, Dr. Madhuri and Dr. Nishant and Dr. Edima. They always help me in preparing this class. So I think we are going in a good way. And the class will be available for everyone on this one, ISNHQ at YouTube. Whenever you, YouTube at ISNHQ. So whenever you can have time, you can see the class. So before we move to the closure of the class, if somebody has any suggestion or a query or something, they can ask here. Dr. Madhuri want to convey something.
So congratulations for a very elaborative class. you covered so many things, including mechanical power. And but mechanical power is a very nice concept which is coming up, and we need to have more of well-designed randomized control trials on it, isn't it?
Absolutely, ma'am.
Yeah. And coming to this lung ultrasound, role of lung ultrasound in ARDS, I think is going to come up in a major way, because now lung ultrasound, we can do it at the bedside, and you can use it for various things for ARDS, starting from the diagnosis with the B lines, then the subpleural consolidations, and then even to the fluid management, then the setting up of the ventilatory ventilatory settings depending upon the patient, and the weaning also, even for weaning, is going to be very, very helpful.
Absolutely, ma'am. Very well said. So, if I may, in couple of minutes, so in initial differential diagnosis of acute respiratory distress, lung ultrasound helps in a big way. So, in finding out underlying causes like consolidations, pneumonia, even viral pneumonias usually have a typical presentations, ruling out underlying acute cardiogenic pulmonary edema and various other differential diagnoses. And once you have made the diagnosis, and you have initiated the patients on various therapies like non-invasive support or then subsequently intubation, as you rightly said, it helps us in optimizing the ventilator setup. It helps us in limiting our fluid administration as well. And in fact, not just that, even we do prone the patients as well. So the response to prone therapy can also be found out to some extent by regular serial lung ultrasounds, although we usually define in terms of PaO2 or PaCO2 improvements in the response to prone. But lung ultrasound and the lung ultrasound scoring system, where we take into account all 12 lung zones and set up appropriate score, the lung aeration score, and serially follow it daily or even more frequently. An improvement in the lung ultrasound score has been found out one of the important strategies in engaging the response of the patients. Even it is used in PEEP titration as well. Like we did not cover because there are so many things into it. So the improvement in lung aeration score can be found out as one of the ways of your beneficial effect, anatomical benefits of setting up the appropriate PEEP can be found out. And towards the end, as you said, for the weaning also, it will help significantly.
Yes, sir.
Yes.
And one more though was this new thing which is coming up everywhere, personalized medicine, personalized medicine. So during the COVID pandemic, we saw that some patients were responding to one maneuver where the others were not responding. So probably the same thing holds in
Yes, absolutely. In
ARDS.
fact, ARDS is the kind of syndrome where the precision medicine have been started maximally in the field of critical care, and there have been a lot of literature on appropriate finding appropriate phenotypes or endotypes of ARDS, where initially identifying the patients and categorizing them into appropriate groups of phenotypes and tailoring the overall ventilator as well as other management. For example, we are initially discussing about use of, say, for example, transpulmonary PEEP for a separate cohort of ARDS patient. Similarly, regarding steroids, use of steroids in ARDS, it's not yet clear that all patients of ARDS we're going to use it. So considerable literature is available in classifying hypoinflammatory versus hyperinflammatory subtypes of ARDS and using different strategies onto them. So it is long way to go, and we are classifying patients mainly for two reasons. One is prognostication upfront, and secondly for identifying which therapy will work in which group of patients. So in coming a decade, I guess most of the randomized control trials in the ARDS will randomize patients after perhaps doing some sort of uh, phenotyping, subphenotyping, or endotyping. That is the way forward, rather than trying all therapies in blanket non-selected ARDS patients.
Yes,
Yeah.
sir. Very well said.
That's what I told you in the beginning also about the individualistic approach in these type of. That's why the precision medicine has a role, because each person of the same height, same gender, may have different, elastic recoils, different respiratory dynamics, different resistance, different immunities, different things actually. Now the phenotype, the genotype, whatever you're going to map, all those things, I think when you do the research, observational studies, or you go for the randomize, I think they get clearer and clearer. Because whatever we concern is the poor prognosis from the patient which has got the poor prognosis, because the patient which die, the patient which has mortality, what are the real reasons behind it? Because if we get into know to those factors, that will be more helpful in at least decreasing the mortality and morbidity. Because the patient which survive may have those factors, and if we just concentrate on those factors, we will never be able to find out the factors which are responsible for the mortality in such subset of patient, although the same demographic profile may be the same of the two patients. So I think in the future, this precision medicine has a much, much better and larger role in the ARDS sector actually. Because I was told every third or fourth patient in the ICU, if we lose it because of multi-organ failure or ARDS. So that is, I think, the way to forward.
Right, sir.
Good class.
Thank you.
So I think till we meet in the next class, and after that we will be meeting in Hyderabad for the Yuvakan. The next class will also be depending upon another workshop. So that's on the airway management. So we will be discussing few case scenarios, the airway management, the next class also.
Right.
Till
Thank
then,
you.
till then, I think it's time to say goodbye and good night. So
Yes.
thank you everyone, and we end.